Welcome everybody to day 2 of the Asia Tech Exchange program. And as we know, we are all dealing with the complex subset, which is the Achilles heel of intervention cardiology, that is the high bleeding risk patients. And I think everybody is waiting to just go down to the live case by Dr. Refai Showkathali so that we can just start off.
Good morning, Dr. Sarita Rao. Good morning,
Good
everyone.
morning, everyone.
Thank you, Medtronic, for giving this opportunity. It's a pleasure to be on here with this expert panelist and to show our live case here. So if there is no other thing, we can start our history of the patient. Doctor, I got a team. I'll introduce my team first. This is Dr. Radha. She's my associate. Sonia is our scrub nurse. We have Mile Avail. He's our technician. And we have the IVUS, the Volcano Phillips IVUS guy, Mr. Avinash is with us. And thank you for the team. And we have runner nurses. And we have the Medtronic team here as well, and our cardiac anesthetist or a standby as well. So that's with that, I will just show you the case history first. So we'll present our case to you guys. You want to talk? Oh, sorry. This is a gentleman in his mid 50s, been a smoker for a long time, but no other medical history of diabetes, hypertension, or anything. He was having chest pain in the past. Apparently, he had an angiogram 10 years ago, and the records of it's not available, but he was advised either a angioplasty or a bypass at that stage, but patient decline, was on medical therapy since then, and unfortunately was not on any medicine for the last few years. So he presented to his local hospital with acute onset of chest pain, lasting for nearly 30 minutes. Went to the hospital there locally, where he was diagnosed with anterior wall MI, ST elevation, myocardial infarction. He was thrombolized with retaplase because they didn't have the facility to do primary PCI. All that was few days ago. So post lysis is symptoms settled, the ECGs had a good resolution, and then I think within 24 hours he was shifted to us for angiogram. So that is his coronary angiography, which was done a couple of days ago by ourselves, and you can see the first view, which is the caudal view, showing that there is a little ostium of the left main, looks a little thromatous, but nothing significant. The distal left main also little looks tapering. The proximal LAD, even though angiographically appears okay, and there is a significant stenosis in the cranial view. You can see a calcified lesions in the mid LAD, and there's a large diagonal branch coming at the level of the lesion, and then we have diffuse disease up to the distal LAD, tandem lesions, which is quite significant. And if you look at the ramus branch, it's got a large ramus branch coming, and there is a focal ostial hazy appearance of the ramus branch. And it's a quite large ramus branch coming there. And then we have the circumflex, which also has got some disease, but it's not a very big branch compared to ramus. The next picture, please. And the right coronary artery. It's quite a dominant right coronary artery, as you can see, quite tortuous right coronary artery. There is a lesion at the ostium of the PDA, large PDA coming from the right coronary artery, and there is a significant stenosis at the PDA. So with this, I would like to ask the expert panelist, how would you proceed, and if there is any suggestions you can give, and then we'll go through what we have done so far.
Dr. Refai, very interesting case presentation here. So we have definitely significant lesions in the LAD, long segment of disease, and we are not very sure about the ostium of the left main and the ostium of the ramus. So have you imaged?
Yes, so I think that's probably everybody would agree that the first thing you want to know is you need to assess the left main bifurcation with imaging, and also the ostium of the left main with imaging. And I have so that is why we are here for today. We also discussed, because of the syntax score, assuming even if you really remove the left main ostium from the equation, if you look at the other lesions and discuss the syntax score, it's coming around 30, which is a little high. And therefore, we also discuss with the patients and the family about the options of CABG versus PCI. But remember, we also mentioned 10 years ago, he was informed about these things. He decided go for medical therapy. So this time, I think we also gave an option saying that if you're not ready for CABG, there is an option of PCI with imaging guidance and to get good results. I think with that discussion, we realized that they actually, the first time it was actually, he was told CABG as the main option. I think he was not offered PCI at that time. That's how he backed off. But at this time, and since we gave the PCI as another option, alternative option in a non-diabetic patients, even though his syntax is high, he's agreed to undergo PCI. So that is the setup. So let me start how we started today. So we are here now. So we started with the radial 7 French Terumo sheath, which is my standard for some complex PCIs. Whenever I go radially, I tend to put a 7 French sheath, and then I used a 7 French EBU 3.5 guiding catheter. And you can see the check shots of the angiogram during this first few shots with a guiding catheter, which is a 7 French guiding, so we have a good filling of the coronary artery. So you can see clearly the ostium of the left main. I could not see any damping with my guiding catheter in the ostium of a 7 French guiding catheter. So I'm pretty confident that the left main ostium is not a major issue here. But I want to assess the distal and the left main and the LAD throughout with the intravascular ultrasound. So these are the preliminary images which we took before we started the case. You can see heavy calcium in that LAD throughout, and a large diagonal branch coming, even though the ostium of the diagonal doesn't appears to be involved. So I started wiring the LAD first, but my aim is to get an imaging of the left LAD and left main. So I put a wire into the LAD. And before considering his lesion was quite tight, I'm sure that the IVUS catheters would not go through. So I thought I'll balloon with a 2 millimeter balloon, NC balloon at a nominal atmospheres around 8 and 12 and 14 to max, and then pass the IVUS catheter was the plan. And that is the 2 millimeter balloons. As you can see, after ballooning, you can see some good flow, large septals coming in. And then I tried to push get my no, go back again. I tried to use my Volcano 20 megahertz catheter, plug and play catheter, but it is remember, it is this little bulky catheter. It was not able to cross that proximal LAD just above the diagonal. So I decided I will go the 2.5 balloon before I put my IVUS in. Next. So you can see the 2.5 balloon, it's not expanding very clearly at that segment. Next one, please. But with a little, I think I went up to 12, 14 atmospheres, I managed to crack through. You'll see this fluoroscopic image, you'll see how the balloon expanded at 14 atmospheres. Yeah, it gave up now, you can see. It's nicely, if you just watch again, you will see that a little expansion it gave up at that segment. So I used 14 atmosphere with the 2.5 balloon just at that segment, and then used the IVUS. Next one. Next one. Yeah, so this is the IVUS catheter, which is at the reference level, at the level of the distal LAD, where our planned distal deployment of the stent. So we have the IVUS images coming now. So you can see, I'm sure whether you can see the IVUS images.
Yeah, we can see them.
Yeah,
absolutely.
So that's the IVUS pullback with the co-registration Volcano Phillips IVUS, which you can nicely see the pullback on the left. It's a co-registration pullback. You can see the calcium there in the mid LAD, very tight lesion at that segment, and coming up there, quite tight at this segment as well. And this is the calcified part which we are talking about. And then we have a large diagonal. The large diagonal ostium looks reasonably okay on this view, on the IVUS. And this is a hugging of the catheter, very tight. And then this is the proximal LAD, which is a decent sized vessel in the proximal LAD. We have references. You can see coming back. And at that level, there's a lot of calcium there as well in the proximal LAD. And then we are coming back again. And that's the LAD, proximal LAD, and coming into the left main. That's left main coming, and the ostium also clean. Right, so I would like to ask the panelist how we proceed, having seen this IVUS, and we will go from here. So what, I mean, yeah.
What about the ostium of the ramus? I mean, that was a concern initially.
That's right.
Did
So,
you?
no, I didn't
Yeah.
image the ramus ostium yet because I was a little worried there may be some haziness there. It could be a thrombus, but I was planning that. Two things I want to decide. Now, the main thing I've decided from this imaging is I am not coming into the left main, having had a area at the proximal LAD of 5.6. Can you show that, please? Even though there is calcium at the so if you see the images there, there is a septal at the level of the septal. There's a large septal coming. Proximal to that septal, the area is very good. 6 is what we're getting there in the proximal LAD. So having seen, and even though there is a circumferential calcium, when I see a 6 millimeter area on the proximal LAD, the osteoproximal LAD, I decided that we should not be treating this at this stage. Because there's a good landing zone for my proximal part of the stent after the septal, which is giving an area of, can you just move that please, IVUS? Yeah, so that's a reasonably 6.4 millimeter luminal area. The EEL is much higher. You can see the 4 millimeter and 3.9 EEL on two orthogonal dimensions. And that's a good landing zone for me to stop the stent at that level rather than coming into the bifurcation of left main, because the distal left main is more than 9. Show the distal left main luminal area. Distal left main. We did mark it then.
I thought there was some calcium even in the.
Yeah, that's right. The distal left main also has a calcium, but we have an area which is giving 9. I mean.
So basically, Dr. Refai, you're thinking that you have a good area, so you're planning to stent from the proximal LAD to the distal LAD.
Yeah.
Now the question arises is that you have a lot of calcium in the rest of the places also. Yeah. What is the calcium modification technique that you're planning to go with? Are you planning to go with cutting balloon? Are you planning to go with rotor?
Yeah. So what I did is, again, so now I've decided that I'm not going to do a left main bifurcation at this level with the area so much in the proximal LAD and the distal left main. I thought I mean, the cutting balloon usage for me is a little less. What I do normally do is 1:1 inflation of the NC balloon at a nominal atmospheres to see if the balloon expands very nicely in 2 orthogonal views. And if it's not opening, then I'll go for a cutting balloon. So what I did is, play the next. I took a 3 millimeter balloon after this IVUS. Next one. Yeah. So this is a 3 millimeter balloon because we know the reference diameter at that is around 3.5. So I use at least 3.25 as a 3 balloon at 14 atmospheres. And this is standard NC balloon. As you can see, it's opened reasonably well. Next one. I took in 2 orthogonal views. Next one. Next. Yeah, so that is the caudal view. You can see little under there, but overall the 3 balloon has nicely expanded. So when I see this, next one please. Yeah.
Dr. Refai, the superior surface of your balloon is still.
That's right. Yeah, that is a little under. I totally agree with you. Back one, please. Back one. Yeah, back one. Yeah. So this is what you are trying to say about. So yeah. I mean, this is something I always have thought about cutting balloons. I think the usage of cutting balloons is extremely high in our part of the world. But if you look at the data from Europe, even the left main studies like EBC main, or from China, the DK Crush V, if you really look at the usage of cutting balloons, even in elderly patients in 70s, it's only 10%, even though they are doing left main calcific body. So if you look at the EBC main, for example, the usage of rotablation is 12%. The usage of cutting balloon is another 11%. Whereas these are all complete left main PCI patients with more than moderate calcification in 60% in both the provisional and the 2-stent strategy arm. But the usage is much, much low. So I tend to use cutting balloon when I feel that my normal NC balloon 1:1 dimension is not expanding or showing typical wasting at some place. I go for cutting balloon. I don't think I routinely use cutting balloons, but I know a lot of people, whenever they see calcium around, they use cutting balloons. But I think if you have a good expansion and if you know that you're going to get a good minimal stent area, I think I prefer not to, but that's the choice of the individual operators. But the data from Europe and the other studies have shown that the usage of cutting balloon, even in heavily calcified, moderately calcified lesions, around 12 to 20%. Not like in every case, but I know here most of people use cutting balloons for all fibrotic lesions, all osteal lesions. I don't think there is any evidence to suggest that cutting balloons has to be used in all fibrotic and calcific lesions, because there's no studies to show that usage of cutting balloon improves your outcome. But I think that in general, I think that's something we can have a discussion about. But I personally feel that if you are non-compliant balloon expands reasonably well and checked in 2 orthogonal views, and there is no wasting, I would prefer to keep that as my option and go for stenting. But
Dr. Refai, the point
my
is well.
trackability, if I have a if I
Dr.
find it
Jaswal.
difficult to track the stent,
Hello.
yes, I would consider that. But at this stage, I would prefer not to use, because there is a diagonal branch coming that segment as well, a little lower down. It's not exactly at the severely calcific segment. I want to see how this behaves and then decide on that. I would like to have the expert panel's opinion on these things.
Dr. Refai, Dr. Jaswal here, I'm
Hello,
Director and
sir.
Head
Hello.
of Cardiology at Fortis Mohali. I have a question about your imaging. You know, why not OCT? You have an angiographically documented diffuse calcified disease, and handling calcium, and a good strategy to handle calcium before you deploy the stent is very important. So
Yeah, 2 things I would like to say why I didn't choose OCT in this place. You remember in the angiographic view, the ostium of the left main looks little suspicious in the 5 French diagnostic angiography. The left main was not that clear on the images which was taken.
We have seen in 7F, you know, that,
At this time, yes. So that was a planned IVUS to start with, rather than, so we planned for IVUS before having seen
I would go by the imaging and the kind of calcium that I see there, and then decide whether I use a cutting balloon, vein balloon, rota, or IPL.
Yeah, correct.
Which is actually the point here, because Dr. Rakesh has brought up a very good point that, you know, even on your IVUS, we are seeing at least a 270 degree of calcification, and the OCT would have delineated it even better. But the point is, if you're seeing so much of calcium, you need to think of some kind of a calcium modification. NC balloon doesn't really do the job. But the point is that once you have the stent in and you've deployed it and you still have a notch and you still have under deployment, what are you going to do except use an IVL as an off-label indication? So there is a rota regret, there is a cutting balloon regret, but once you've deployed the stent, there is nothing that you can do except open an expensive IVL balloon. Yeah. Which is why we always feel that, you know, preparing the bed is so important.
I think at this stage, one can use the IVUS.
There is disruption of the polymer, and it may not.
Absolutely, which is why it's an off-label indication, and that would be question about disruption of the polymer. But there is the only thing which is left when you end up in a situation like that, and it's off-label. So it's always better to prepare the bed very well before we go in. We are seeing an NC balloon with some amount of, you know, under expansion in the proximal segment. So and actually a cutting balloon is not very expensive and not very difficult to track in. So if you can take that in and break up the calcium.
You know, and my feeling is if you have a concentric calcium, then if you use a NC balloon at high pressures, you must still crack it. But if you have eccentric calcium, then whatever, if you use just an NC balloon, that is never going to do the job, because it will only expand in the non-calcified segment. So I would agree with Dr. Saritha and Dr. Jaswal that in case of a heavily calcified lesion, it is always best to prepare the lesion first, rather than, be in a hurry to deploy the stent and then regret later. Yeah. Because there's hardly any choice after that.
I think he has got an IVUS on the table. He can check the effect of, NC balloon.
Yeah, we can see that. No,
so 2 points I would like to make. I think there's a very important point made about the OCT. The reason why the OCT was brought up is because you have a calcium scoring on OCT, which can tell you, whereas IVUS, we don't have the scoring system of 4 up to 4 to decide, and we have calcium modification study. I think that's a very valid point. I take that point in account. But having said that, as you rightly somebody mentioned to us, I think I would rather do an IVUS again to see the expansion before, rather see, as you're all discussed, cutting balloon, the usage is high because it's easily available, it is fine. I don't have any problem, but my problem here in this particular situation is there's a large diagonal, the ostium is not involved, and my cutting balloon may damage a large diagonal and I will end up in trouble. So I would prefer to put the IVUS catheter and look at the expansion of the luminal area at that segment before I take that. And we all have to agree the fact that the OCT measurement of OCT scoring of 4 is also just not validated in a big studies. It's been just proposed by a group of people, and that I agree, we all agree with that and we take that into account. But there's no study so far to suggest that cutting balloon changes. I agree with your rotarygrat and all those things, but if you have a lumen area which is much more than what this is the place where we want. I've just put the IVUS back again just to see what has happened. Yeah, so the rotor, I totally agree with the rotor regret and all those points, but at the lumen area of 6, 4, 4.5, I would rather, if I'm going to use either a cutting balloon or an IVL is my choice here. And the depth of the calcium is not very well assessed in IVUS. I totally agree with that. Even though you have a calcific concentric calcium all around.
Can we see the IVUS on the
Yes,
bigger
we're going to
screen?
pull back now. Yeah. Can you show the IVUS? Can you see the IVUS now?
Can you show us on the bigger screen, please?
Can you show on the bigger screen? Anybody?
We are basically looking for any cracks in the calcium. That is all.
No, and the luminal enhancement, luminal area.
Yeah,
because
the luminal area will only go once the calcium cracks.
correct,
Right?
correct. Yes. So shall I pull? Can you see it now?
Yeah, we can see. We can see
The
the,
big screen,
we
yeah,
can see the
yeah.
IVUS.
I'm just.
Not on the full screen, but we can
I'm
see
starting
it
my pull back now. So. That is the spot we found it. Yeah, I think that one spot I can see. I'll just go back again just because it's a. So that is the heavily calcific part. You can see the, I think it come back a little bit. So this is the place we are going to thinking of going down.
Yeah, this is more fibrotic actually. There are specks of calcium, but I thought we saw more calcium. More
Yeah, there you go. That's the
yeah.
place.
This
That's
is the
one
calcium.
place. Yeah. So let's put a lumen area on this. Stop it and just put the dimensions here. No, that one spot, the last spot. That is the most calcific
fracture
spot.
at 4 o'clock also.
Yeah,
Small
correct.
fracture.
Yeah, you can see that exactly at 11 o'clock. You can see a fracture there.
4 o'clock.
What are the dimensions you're getting?
This is what Dr. Naveen was saying, that if you have got a concentric calcium,
I think in this case I may use a cutting balloon because you can see we have only 2.3 is what we're getting dimensions. So I may use a 3 cutting balloon here. Having seen this now, that it's only at dimensions of 2 and 2.4, which I think is not the 3 millimeter balloon at that particular mild wasting segment is not opened up properly. So at this level I'll use a cutting balloon. 310,
That's a good idea.
That's right, yeah.
Also, just for the
So
interest
with the
of all
imaging
people-
in imaging with us now, we can always at each step we can check it before we go for that.
Yeah, we are fully under control.
Absolutely, that's the advantage of
From
imaging.
that, I think that area has lot of, fibrotic region area.
And
also.
a concentric calcium at that, which even though there is a slight crack at 11 o'clock I saw, but
But there is a recoil, we don't have area there.
So this is a 3x10 cutting balloon. I think it's Wolverine or Flextome, whichever we have here. I don't know. Negative. Negative, please. Negative.
So you're going in with the cutting balloon.
That's
Dr.
right. So I think they're given a Flextome to me. If it goes through, well and good. If not, I'll switch over to Wolverine because the crossing profile we all know
Profile,
it's much better with Wolverine than the Flextome. We also have Angiosculpt, which.
So just because we have time and we were discussing IVUS and OCT, and In this case, of course, there was no damping in the left vein when his guide catheter was engaged. So we didn't feel it
that's
was
the part, right?
significant at that point. But whenever, you want to image the ostium of the left vein, and not all centers will have both IVUS and OCT. And if you want to see it with the OCT, the ostium of the left vein, you can just take in a telescope. The telescope has a proximal 2 millimeter infrared compatible segment. So you can still image the ostium of the left vein with that.
Yeah.
So we
No,
had
the
it,
OCT, I mean, if the left vein is very large, then OCT creates a problem. Then it doesn't really image the wall very well.
yes.
So which is why we take that in.
As a dictum, I think if ostium is involved, we should prefer IVUS to.
Absolutely. I think that's one of the reasons we planned for IVUS to start with. But as you rightly said, we also have OCT. We could have switched over. But then since it was planned,
No,
everything...
that's okay. IVUS is equally good. I mean, OCT just gives you more quantification.
Correct, of
calcium
calcium.
is better seen. That's all. Otherwise, IVUS gives you a very good idea about the circumferential calcium and all that.
Yeah, I think that's... so what's the negative?
Well, let us see whether your cutting balloon goes in and what happens.
About 3 situations where I would prefer OCT to IVUS would be 1 ACS, 2 where there is calcium,
Yeah, negative.
and 3 where the images are not very clear with OCT, and there are few diagnostic dilemmas which have been left. But
Yeah,
first
that's
2
our
are
cutting
very
balloon in the segment we have. So you can see the lesion there exactly. I don't know whether you're able to see your screen on the
we can
Heart
see that on the
Navigator
left.
roadmap.
Yeah.
That is exactly the level of diagonal. That is the worry I had before I used the cutting, but we know from the data from the imaging that the expansion is not enough and there is still calcium. So we got the Wolverine ready. So let's go to the nominal pressure.
Why do you not have a wire in the diagonal?
Yes, that's a good point. So the plan was to put the diagonal before I get the stent in, but now we're going to use a cutting balloon. We can't use the wire anyway, so let's do that and then I'll put the wire. Yes.
Oh, you can. Still.
8.
So cutting balloon doesn't preclude you from
Doesn't
using a.
damage the wire. So you
Not
can only
necessarily.
wire.
I agree. It's a longitudinal blade, so I totally agree with you that it may not, it directly doesn't compromise on, but there is a small possibility. I agree with your points that
No,
it's
barring
not
rotor,
like
nothing else. I mean, you can
down.
use IVL, you can use cutting with
You
a
can use it.
side branch wire. There's no problem.
I got the wire in the ramus. I may just take it and put it.
Fair
That
enough,
is,
fair
yeah,
enough.
yeah, go there.
It's okay.
Go
I mean,
there.
carry on with
Go
your
there,
own
go there, go up
strategy.
to 10, 12, 8. So that is the cutting balloon. I'm just rotating the blades at each, and you can see the expansion. What level are you? 6, 8, go up to 8.
And your diagonal ostium is clear, so nothing's going to
Yes,
happen
yes,
to you.
that's
Yeah,
very
I won't
valid
worry
point.
about it.
Down.
Yeah. But I would still like to just have a
I keep a
wire in
wire,
it.
yes, definitely when I'm
Always
putting the
better.
stent, I'll keep
Always,
the wire.
always better.
Okay, so go up to, we'll see now orthogonal view, just go up to 12, 8, 10. Mile, can you go to orthogonal view? So that's exactly the level where PA caudal, yeah.
So
Over the table.
question for the panel, do you all like to go as to 1:1 in the cutting balloon, or does somebody like to downsize?
I generally go a little lower. 0.8, 0.9 is safer. That's all. And then you can go up a little higher pressure than the nominal pressure. That doesn't really matter. It's not necessary to only end up at 8.
12. So this is a 275 they given me. So I'm going up to 12 atmospheres, which is giving around. So at least this is cutting, even though there is a little thing, but at least it's cutting. So I'll use a 3 balloon again, down. Standard NC balloon ready.
There's still a notch.
Yeah.
Yeah, the superior surface, I think there's a huge chunk of calcium.
Calcium right over there.
Go there.
Are you planning to use lithotripsy?
And open up. No, not at the moment, but let's see.
This is a 2 what size cutting was this?
275.
Okay.
Go up there. Go down.
You like to go up with a 3?
Down, yeah.
Yeah, that's
No,
what
I think this is a 3 balloon, right? 3, yeah. 275 is the previous one, I think. Yeah, go there. Go. 12. See, I think there is a good expansion, as you can see. There is a little notch, but we don't want to crack that notch and cause perforations at the same time. So come back to cranial view. Let's see whether that is opening. See, I think we all know that the outcome depends on what your last stent area, which is more important than all these. Down,
You like to go up to 18.
down, down, down. Okay, let's use a 3 balloon. Go up again one more time. Just go up to 8, 10, 12, 14. See this level, I think it's this is exactly where that concentric ring of calcium. Just give a puff. Make sure there's no puff.
In case there's a little doubt about the expansion, now you
As
can
you
use
can
an
see the
NC balloon at
dissections
high
there
pressure. I think
very
yeah,
nicely.
that's okay.
That's expected as with the cutting balloon. So let's use a 3 balloon before we
Yeah, you can take a
decide the
3
next
NC and go
strategy
up
here.
high pressure.
Yeah.
We are overshooting our time limit here.
All right. Okay. So if you want to go to the other lab, I think there's one more happening, right?
No, we
I
have
think-
one live case today,
Oh,
and the
okay.
second is
I think there's a case in box by
Okay.
Dr. Yeah,
by Dr.
Fix the wire.
Ankush Gupta.
yeah, Ankush,
So,
you have
Dr.
your case
Refai,
ready.
can we come back to you
Yes,
just
please.
to see
Yeah,
what you
yeah,
did?
Yeah.
So meanwhile, we'll have Dr. Ankush Gupta doing his
Let me put it
HBR complex case, and then we come back to you to see what
Sure.
exactly happened. Very interesting case, Dr. Refai, a lot of interesting discussion points and great learning case. Thank you.
Thank you.
Dr.
Refai, we are back with
again.
you.
Fantastic. Excellent. So let's show. So we're nearly going to show you, nearly finished now. Let's show the pictures. So we left you after the cutting balloon inflation with the Wolverine cutting balloon, and then we were planning to do a 3 millimeter balloon, NC balloon. So go back. Before the stent, back. Yeah, back. That's it. Fine. Yeah. So that is the 3 millimeter NC balloon after we use the cutting balloon. That I think this is the level we left. Next one, please. So we use a 3 millimeter balloon at 14 atmosphere. Next one. Next. Yeah, so this is the place, you remember we had this caudal view. There is a little under expansion of the balloon at the distal edge of that balloon, but now with a 3 millimeter balloon it looks more expanded. Next. So this is the picture after the 3 millimeter balloon. So we have a reference vessel diameter from the IVUS before for the distal or the mid LAD. Next one. So we decided to go for a 2.5 balloon. At this level, I changed my wire from the ramus to the diagonal as we discussed about. And now we have a 2.5 by 30 resolute onyx stent at that segment because I want to purposely don't want to overlap the stent at the level of the diagonal. So I decided to take a shot just to stop distal to the diagonal. Next one. So that's the balloon, that's the stent after deployment. You can see a little under deployment of the stent at the distal 20 millimeter. So we just did a check shot to decide the length of it. So I went back with the balloon a little higher inflations. Next. And then decided to go for the next stent, which as we planned to stop it proximal to the septal branch, jailing the diagonal. So this is the 3.5 by 26 millimeter onyx resolute. Next. So that's that is the deployment of the 3.5 26 at 8 or 10 12 atmospheres. You can still see there is a little two segments where it looks under deployed. So under expanded rather. So I just went the same balloon, just inflated a little bit distally, and then went with the 3.5 short NC balloon, which is next, which is at 8 or 10 millimeter NC balloon. And I went up to 18 atmospheres and 20 atmospheres at different segments. And you can see the expansion. Next. Yeah. Next. So I use the same balloon to just do a little bit more there, but in a very gentle way there. Next. So this is what we had, and then what we decided to do is an IVUS measurement of the assessment of the stents. So this is the IVUS. So you can see. Can you see the IVUS on the screen?
Yeah.
Yeah, okay, so that is the IVUS pull back from the distal edge of the stent. You can see there is a little under expansion at the very distal edge here, and then we got good stent area, and you can see the cross-sectional area. In this place, there's a little under expansion, but you can see as we come back, there is a good expansion of the stent. We can see the co-registration there as well. So we are more interested in the segment where the significant calcium was, which is exactly coming now. The slow pull back, that is the luminal area where we are, that is this circumferential stent at that segment. So you can see there is the edge of the stent coming now. There's no dissection at that edge, and you can see the calcium from the native coronary artery. So with that, we decided to do the MSA at different segments. Let's show the MSAs at different segments. The distally, we haven't got a good MSA at that segment, which we saw in the IVUS. But in the proximal part of the first stent, we are getting around about 8 millimeters, 7.98 millimeters square, which is a very good for a mid LAD, proximal LAD area. Just pull back more and show a couple of MSAs, cross-sectional areas. Yeah, there. Yeah, there. Remember, there is some disease in the very proximal LAD, so I don't want to go. This is 9.5 we are getting. So 9.5 at LAD is excellent, so I don't think we should do anything more at that segment. So what we did is, because there is under expansion at the distal edge of the stent, we took a 2.5 balloon, NC balloon next. So just to post dilate that particular part where we saw some, I went up to 18 with a 2.5 short NC balloon at the distal segment, and this is what we got. This is the final angiographic result we have of the two stents deployed in the LAD. Next one, caudal. We haven't taken the caudal yet. We'll take one caudal, Mike. Go to caudal. Spider.
Dr. Refai, is there any malapposition at the proximal edge of the stent?
No,
Proximal
can you
part of
show
the
me
stent?
that IVUS? There is no malapposition. This is
Proximal 3 or 4 mm.
I think
you mean
there's a branch coming out there, which is why it's like that.
Yeah, there's a big branch coming, but you can see
Okay.
that's the edge of the stent. You can see the edge of the stent.
Septal.
Yeah, that's it. Caudal, my LAO caudal. So are we going to take a caudal shot? PA caudal, yeah. Okay, we'll take a PA caudal nicely. But we know there is a disease in the proximal LAD, but it's not significant enough proximal to the stent. So you can see a step up. You can see in the angiographically, you can see a step up from the native LAD to the stent segment. But the stent is flowing very nicely. I think with that, I'm going to stop this LAD. I'm going to concentrate on the right coronary artery, which we have the proximal, this ostial PDA lesion. And that is the last picture. We'll try and pull the wire back. Okay, ready?
So good result, Dr. Showkathali. You were also going to image the ramus.
Yes, I mean, I think now whatever even if I going to image the ramus at this time with no stent in the LAD, there are two options I have. If I image and find, but angiographically there is not a tight lesion as such, maybe some haziness, some calcium, but I am not going to put a stent in that ramus. So if at all possible, these kind of situations, if it's significant, I may use a DCB. Because here I'm not going to do a bifurcation stenting. There is a possibility that he may need a re-intervention at a later date for that proximal LAD. Maybe in, I don't know, depending on how, thankfully he's not a diabetic, no hypertension. He's been a smoker, is the only risk factor, and he promised me that he's going to stop completely. His LDL levels were around 85. So I'm assuming that with that MSA, he should not have a problem for at least next many years to go. So in terms of ramus, I think that's something I would like to ask the expert panelist. Would you do something for ramus at this stage? This is an anterior wall ST elevation MI patient, and you have a bystander disease, which is a very focal haziness in the ostium of the ramus. I'm not sure whether I would do anything for that, having got a LAD result so good. I'm not sure what the panelist feels about it.
I think you can tackle it in later on.
Yes.
You can assess the
Yeah, it may be just the thrombus sitting out there, residual thrombus sitting
right.
out there, which may just vanish later on. But
Absolutely.
it
I think
may
that is
need a
what my impression
reassessment
was.
later on. Yeah.
Exactly. If we are going to put a stent into the left main tail lady, I was planning to definitely assess
Then you
it
could have
carefully.
tackled it. Anyway, you can't do anything to the isolated ramus ostium.
Absolutely,
There's no way
absolutely.
you can tackle it safely. You'll have to do a left main to LAD and then a bifurcation to the ramus.
Excellent. I think we are ready to go for the RCA. I mean, I'm not sure whether you want to stay on live or
Shall
you're going to
we,
go. For
So
Dr.
thank
Ram,
you.
can we go ahead with the other presentations now?
Yes.
Thank you so
Thank
much.
you,
Thank you
Dr.
for the
Refai.
Thank you. Thank you so much.